It is important to mention that this video is meant to provide you with the latest and most up-to-date information about concussion treatments and management. It is not meant to be used to approach equestrian-specific concussions, rather used to learn how to approach concussions when dealing with athletes. This case study is meant to be a learning tool to help guide students through general athlete-based concussion protocols. The SCAT-3 is a standardized tool for evaluating injured athletes for concussion. It includes sideline assessments, cognitive and physical evaluations, and symptom evaluations. Common symptoms include somatic, cognitive and emotional, physical signs, behavioral changes, cognitive impairment, and sleep disturbances. This test would be completed immediately post-concussion, and then once graded protocol is completed, comparing baseline values to post-concussion results and results after graded return-to-play rehabilitation.
Concussions are characterized as a combination of metabolic, physiologic, and structural damage to the brain. Several studies have suggested that mild traumatic brain injury results in dysfunction in the autonomic nervous system, and specifically induces cardiovascular control dysfunction between the autonomic nervous system and the heart, involving uncoupling of the arterial baroreceptors. As a result, concussed athletes may show cardiovascular dysfunction during exercise. Furthermore, rest post-concussion will decondition the cardiovascular system, thus affecting the autonomic nervous system and impairing cerebral blood flow control. MRI studies have also shown a dysregulation of cerebral blood flow after concussion. Other evidence suggests that concussed individuals may exhibit related autonomic nervous system dysfunction, including orthostatic intolerance. A contributing factor may include arterial blood carbon dioxide tension, which regulates cerebral blood flow and is a function of pulmonary ventilation. Research has shown carbon dioxide tension to be diminished in concussed individuals, thus reducing cerebral blood flow and contributing to orthostatic intolerance. In terms of management of concussions, studies therefore suggest that exercise is implemented into a rehabilitation protocol, as exercise post-concussion has been shown to increase cerebral blood flow control. MRI studies have also shown that concussed individuals show excess metabolic activity and are easily fatigued during prolonged cognitive activity. However, subthreshold level exercise has shown that brain activation patterns are restored to normal in concussed patients.
A study done by Mytrasiak et al. Examined the effects of voluntary exercise on concussion recovery and the influence of restricted socialization on emotion and recovery. Voluntary initiation of exercise therapy within 1 to 3 days of concussion was seen to significantly improve both motor and cognitive functioning. Exercise also had a positive effect on gene expression, which could aid in the secondary bioenergetic response designed to promote cellular repair. The absence of TERT, commonly known as telomerase reverse transcriptase, is associated with aging and disorders. Activation of TERT can be linked to the improvements in telomere length identified in this study. There was a greater restoration of telomere length in animals that returned to exercise earlier. Moreover, voluntary exercise within 1 to 3 days post-concussion was found to be beneficial to motor and cognitive outcomes and mild traumatic brain recovery. Timing of return is often dependent on being 100% symptom-free. Headache is a common symptom of acute and chronic mild traumatic brain injury and is a limitation to all activities, including exercise. However, in patients with pre-existing headache, being 100% headache-free may not be realistic. Thus, the well-known general benefits of exercise and those to brain health is a potentially beneficial treatment for improving traumatic brain injury outcomes, with the condition that they are implemented while monitoring for individual independent adverse effects.
Level 2 evidence shows that vestibular rehabilitation has been recommended for individuals with persistent post-concussion symptoms. Furthermore, those who undergo vestibular rehabilitation are more likely to be medically cleared within 8 weeks versus control groups. Vestibular exercises are as follows: eye-head coordination, sitting balance, static standing balance, standing dynamic balance, and ambulation exercises. Of the vestibular rehabilitation exercises, eye-head coordination, standing static balance, and ambulation exercises had the most impairments and were most commonly prescribed.
Peters-Price See-to-Play Concussion Protocol. The goal of this program is to have patients complete 10 stages of visual and coordination exercises without developing concussion-like symptoms. Upon the beginning of a session, patients are asked to rank their symptoms from 0 to 10, 0 being completely asymptomatic, 10 having most severe symptoms that they have felt since the injury. When patients indicate that they feel the return of their symptoms by ranking of 2 levels, the exercise is discontinued. Stage 1 includes retinal examination and prescription of second pair of reading glasses. Stages 2 to 9 include a variety of exercises that slowly progress and become more challenging. Stage 10 ends with a visual edge computer testing that improves your timing, visual perception, decision making, and your overall visual system.
Cognitive rest is widely recommended in consensus statements and concussion guidelines. An initial period of rest appears to be beneficial for most individuals. Prolonged cognitive rest beyond the acute stages of the injury may result in the athlete developing concussion-like symptoms unrelated to the injury, including anxiety, migraines, and sleep disorders. Reducing the time interval between concussion and voluntary exercise restores motor impairment, short-term memory, and alterations to gene expression. In summary, acute rest would likely be beneficial to our patient, but not beyond the acute stages.
With a stepwise progression, the athlete should continue to proceed to the next level if asymptomatic at the current level. Each step should take 24 hours, and if any post-concussion symptoms occur, the patient should drop back to the previous asymptomatic level and try to progress again after a 24-hour period of rest.
Vestibular rehabilitation alone is not statistically proven as a predictor of return to play. However, it should not be discarded as a treatment option. Level 1 evidence shows that C-spine physiotherapy with vestibular rehabilitation significantly increases the likelihood that an athlete will be medically cleared to return to play within 8 weeks.
In Peters-Price study, average time to return to play using visual therapy was 5.8 weeks. 61% of the patients benefited from the visual therapy exercises. 31% had their symptoms resolved with prescription glasses, and only 8% did not present any visual symptoms, therefore did not receive any visual therapy treatment.
In conclusion, we would advise that our patient starts off with an initial period of physical and cognitive rest, followed by light aerobic exercise, keeping at 70% of his maximum heart rate, and then moving on to sport-specific exercise and riding activities. After this, we would suggest non-contact training drills and progressive resistance training and full contact practice on the horse. And then finally, after all of this, he can return to play or competition. We would also recommend visual therapy and rehabilitation exercises because they may be of benefit if visual symptoms persist during graded protocol.